Hi, Daryl Baskin here in San Antonio. This is part two of a three-part series on central serous chorioretinopathy. The primary focus for these lectures are towards the level of the resonance, and the last lecture was primarily about risk factors, brief history, pathophys for central serous chorioretinopathy. Remember, ask about Flonase, inhaled steroids, and ask about snoring, sleep apnea. This one is going to primarily focus on imaging differential diagnosis. And I don't have any financial conflicts of interest, and I may discuss off-label uses. When somebody comes in with central serous, they typically will report some dimmed vision, a little bit of blurred vision, is another word. They may mention, if they're particularly astute and they have a lot of subretinal fluid, some micropsia. That's a relative smaller image in the eye that's affected with the central serous, because the photoreceptors are spread out a little bit more. The same image only stimulates a smaller number of photoreceptors. Metamorphopsia, which is sort of things that are straight appear to be wavy, and maybe even some color vision changes, particularly blues and yellows. So there's some other things you need to think about when somebody comes in with subretinal fluid, particularly under the fovea, and we'll kind of go through some of these. This is a patient with an anomalous appearing optic nerve head, vessels emanating from the edges, and a prominent area of subretinal fluid almost involving all the macula. And that fluid, as you can see in this OCT, goes almost all the way to the nerve. Certainly there's an intraretinal fluid component that goes to the nerve. You can see an outer macular hole. This patient also had kidney problems and was diagnosed with papillorenal syndrome, which is caused by a PAX2 mutation. This is another patient with subretinal fluid. When I first saw them, I thought they had age-related macular degeneration. However, after I had started anti-VEGF therapy, I noticed that they had subtle angioid streaks, and they actually had a choroidal neovascular membrane due to pseudoxanthoma elasticum-related angioid streaks. I subsequently did a genetic workup, and he had an ABCC6 mutation. He also had a history of a fempop bypass that's consistent with folks with pseudoxanthoma elasticum. They get peripheral arterial and cardiac disease earlier in life than usual. This is his fluorescein angiogram that shows that diffuse leakage and some hypofluorescent, well-circumscribed areas consistent with some intraretinal hemorrhage and subretinal hemorrhage. So again, you got to do your imaging, you got to do your due diligence in order to sort of sort out the cause of some of these various entities leading to subretinal fluid. You can see subretinal fluid perhaps here, but also there's this sort of creamy yellowish material under the fovea. The other eye looks very similar. Here's the OCT, and this patient had Best disease. This is a disingenuous first OCT for me to show you, because this was not in fact his first OCT, but you can see the subretinal fluid here, some drusen-like deposits overlying the RPE, and 1 month prior he presented with many chorioretinal folds, a thickened choroid, diffuse subretinal fluid, although it doesn't show up in this OCT, and he actually had Voigt-Koyanagi-Harada syndrome after an extensive workup. This is his sunset glow fundus, although best appreciated on clinical exam when you get a slit beam that sort of scatters once it hits that atrophic RPE and gives you that glow. This is another patient. This can be confused with central serous. All of these can, but this is one that gets a little closer to home. This is a primarily choroidal process as well, and you can see the blister of subretinal fluid. You could see on the OCT subretinal fluid there as well. You can also see this pigmented peripapillary atrophy and some RPE changes close to the nerve on fluorescein and ICG. There is an area of leakage, hyperfluorescence, superior temporal to the optic nerve, as well as this sort of fine vascular network consistent with polyps that's seen both on the FA and the ICG. So this patient had polypoidal choroidal vasculopathy, I think originally described as posterior uveal bleeding syndrome, and that was described in Philadelphia, I think, by Dr. Klein. And so here we have a patient with retinal stria, subretinal fluid, and some RPE folds. The OCT shows subretinal fluid as well. And on the fluorescein angiogram, sorry, I don't have any later images, they kind of washed out. You could see these kind of linear, scattered, hypofluorescent streaks consistent with the chorioretinal folds. And then in the later one, the later image at 48 seconds, you could see these multiple pinpoint white dots. That goes along with something called a starry night sky fluorescein angiogram. And on that differential are a bunch of things, including what this patient had, which was uveal effusion syndrome. A lot more subretinal fluid is present inferiorly that's consistent with that disease. This doesn't look like central serous, but this is probably the most commonly misdiagnosed entity or confused with central serous. And you can see that kind of grayish-green sort of membrane, that coloration just in the temporal half of the fovea. And then on OCT, you see subretinal fluid, a low-lying PED, all features that you can see in central serous. But then if you look at the other eye, it's obvious that this patient has macular degeneration based on these large, soft, nearly confluent drusen. So when doing a workup for central serous, imaging is critical. It's great. It's great when you don't have to do any lab tests or x-rays. You just can figure it all out in your own office. So I'm going to go through some color fundus photos first. This is that typical appearance, somebody with acute central serous chorioretinopathy with the subretinal fluid. You can see that sort of well-circumscribed curvilinear change in coloration that's consistent with subretinal fluid. That can also kind of sometimes look like a PED, so you have to be careful. And then you see the sort of yellow, tiny punctate subretinal precipitates. This patient has diffuse subretinal fibrosis, as well as some RPE metaplasia, some RPE modeling in the temporal macula. The patient's fellow eye, the pseudophakic, showed even more extensive RPE changes, as well as you can see this shadowing of the blood vessels, particularly that arterial just above the fovea, and that appears to be consistent with either subretinal or intraretinal fluid, and I'll show you the OCT later in this lecture. So this image shows again another subretinal fluid blister closer to the nerve this time. So you want to look at the nerve closely, make sure there's not an optic nerve pit, and another one of the same thing, just a right eye. Optical coherence tomography reveals a lot more detail than the fundus photos in most cases, and here you can see these outer segments that are elongated with that arrow pointing to them, and then just above the original scan in the same patient you could see a small pigment epithelial detachment. This is sort of like a smoking gun for central serous. You almost always see this tiny little PED poking up, and in the acute phase, and in the chronic phases it's a little bit more complex. Here's a little bit of just a review of anatomy, but also specific to central serous. These little green dots that I put along that line represent an anatomical boundary that's not normally seen, and I'll tell you what that is in just a moment. As I go through these different lines, I want you to play along with me and sort of say to yourself what each line is as a review. So this blue line represents RPE Bruch membrane. This next one, this green one, if you can see it over to the right, is the interdigitation zone. The purple one is the ellipsoid zone. This yellow one is the external limiting membrane. Here we have, in the center, that green shaded area, the outer nuclear layer, and then this blue one represents the outer plexiform layer. The purple represents the outer segments that haven't been phagocytosed by the RPE, so they're building up, and to me this represents some fairly healthy photoreceptors. They're still making outer segments, they're still getting some nourishment. It's when they stop making the outer segments that I get more concerned about photoreceptor health and permanent irreversible loss. These little tiny hyperreflective foci are different than the ones you see in diabetes. I conjecture that possibly these could represent some apoptotic photoreceptor nuclei. I don't know for sure, and I don't know if my literature search was broad enough. Maybe somebody else has already described these, but I do wonder what they are. And getting back to that little green dashed line, that represents the outer boundary of the outer plexiform layer. You don't normally see that. In fact, the blue shaded area shows the full thickness of the OPL. The OPL normally is only hyperreflective in the inner third. The outer 2/3 is isoreflective with the outer nuclear layer. That led to some confusion in the early days of OCT. I just want to show this to highlight the difference between color fundus photo and the infrared. You can see how much easier it is to see the subretinal fluid sometimes with these IR photos. There is also a choroidal thickness measurement there. Those calipers show 347 microns. Unfortunately, I don't have a lot of EDI, enhanced depth imaging images, because I just haven't asked my photographers to get that lately. And so typically, I think Rick Spade described most folks with central serous having an average choroidal thickness of about 500. So this is much thinner than he got. And it did improve a little bit upon resolution. It's, maybe, 5% better. So Again, normally there is an increased choroidal thickness in CSR, as well as PCV, polypoidal choroidal vasculopathy, and VKH, Voigt-Koyanagi-Harada syndrome. This is just a few more OCTs of some appearances you can see, because there's a lot of variability. You don't just get subretinal fluid, especially as they get more chronic. The RPE gets more disrupted. It's been violated multiple times, and now you start to see this decompensated RPE, and then the retina oftentimes secondarily gets atrophic due to the RPE changes and chronic subretinal fluid. So you see subretinal fluid, you see multiple PEDs here, and temporally, superior temporally on the right side of the image, you see almost like a subretinal fibrotic sort of hyperreflective space-occupying lesion. So this is a patient that actually may not have central serous. This is a large PED, asymptomatic patient, monitored for a few years, hasn't changed in size since I've started seeing her. You can see the hot cross bun sign on the fluorescein angiogram. You see the RPE changes on the color fundus photo. This could also be due to PCV, it could be AMD, there could be some other thing out there that causes these that is not related to any one of those three entities. So again, somebody I monitor, give an Amsler grid to, talk about sleep apnea and discontinuing any steroids. Here are a few just random OCTs that you might see more in chronic disease. Again, you get the intraretinal fluid usually happens after subretinal fluid's been there for a long time. I've never seen intraretinal fluid with these little septae in a brand new case of acute central serous. Here's some more subretinal fluid PED with this little tiny hyperreflective line within the PED that may represent some delamination of Brooks membrane. And again, notice on the right side of this image there's almost like subretinal fluid, but it might just represent some atrophic photoreceptors that are no longer making outer segments because the interdigitation zone's gone. This same patient is a patient of mine for several years now. He tells me, in fact, we were talking about one of my studies a couple weeks ago, and he said, Doc, I'm type A, I have reflux, I have sleep apnea, I am the poster boy for your disease. And he's right, I hadn't even thought of him as type A. I kind of always think of my patients as pretty laid back. But it's something to think about when you've got somebody with chronic disease. Early intervention is key, and we'll go into that more in my next lecture. That might take a month to come out, but my next lecture eventually we'll talk about that. He had an acute exacerbation, same patient, subretinal fluid. This is how it looked on his color fundus photo. Here's a little bit better close-up image of that. You could see that he's got these RPE changes along his inferior temporal arcade and temporal macula, but the autofluorescence really keys in on these changes. If you look at the superior portion of this image, it's kind of got a gray, uniform, homogeneous gray background outside of the blood vessels. That's your normal RPE autofluorescence. When the RPE gets overloaded or gets sick, has taken on too much lipofuscin, A2B, other fluorophores that come from the outer segments, it becomes hyper-autofluorescent, and then when it dies, it becomes hypo-autofluorescent, becomes black. So that section down at the bottom, we call this guttering, by the way, when you see these troughs of fluid that have this gravity-dependent distribution. That guttering isn't specific to central serous, but it tends to happen only in things that cause chronic subretinal fluid that tracks inferiorly. So you can get the occasional choroidal nevus that does this. You can get a CNV that does this. You can get choroidal hemangioma that can do this. But again, it's not very common with macular degeneration, and it's not very common with most CNV either. So when I see this in a multifocal pattern, the first, second, and third thing I think about are central serous chorioretinopathy. So let's go to a couple others that aren't quite so textbook. This is another patient with acute central serous, never had a previous episode, and I want you to notice he's got a little bit of darkening of his autofluorescence, centrally in the same distribution as his subretinal fluid, and I want to sort of convince you that this subretinal fluid is actually attenuating the RPE emission of that autofluorescent wavelength. So it's not that the RPE is damaged, it's just that it's got fluid overlying and it prevents the transmission of the full autofluorescence wavelength intensity. This patient has very chronic appearing changes. You see his autofluorescence, his RPE is dead. So a treatment for him is probably not going to make any difference visually. And then if you look at his OCT, he's the only patient I have like this. I have a couple of other AMD patients that have this sort of picture, but he's got this large cystoid space, broken all the septae that were there, all the Mueller cells that were holding that retina together, and this patient does not have juvenile X-linked retinoschisis. This subretinal or intraretinal fluid probably started out as subretinal and then migrated intraretinal and then broke down those spaces, so those walls. And here's another image. This is that same patient. Now we're going to go on to fluorescein angiography. There are three principal patterns. I'll show you an example of each. This is the early arterial phase. Then you see this little white dot between the fovea and the nerve, and then it becomes a little bit larger. It doesn't move anywhere. We call this the expansile dot pattern. And this is the most common pattern you'll see, especially in acute. When you get something that's chronic, and you can see, again, intraretinal fluid in a patient with central serous, you have to think chronic, but sometimes in fact, when this patient first presented, we had no idea what they had. This is kind of in the early days of when we first got our Heidelberg in Philadelphia. But you could see intraretinal fluid, subretinal fluid, and sub-RPE fluid. Kind of has it in all three spaces. Early on, he's already getting some mottled hyper and hypofluorescence, and then later it just becomes more of sort of a staining pattern, maybe a couple of areas of mild leakage. So we call it a diffuse pattern. It's very typical in a chronic case. And finally, the smokestack pattern. Here's another patient, acute central serous. You see the tiny little white dot already. It's a little bit vertically elongated, and then it just goes up. And this is courtesy of Dr. Bill Benson, one of my mentors. And we're just kind of marching through, and you can see that there's beautiful smokestack. It's not beautiful if it's yours, of course. And then here's just all three patterns. I'm going to show you little movies: expansile dot, diffuse, and here's that smokestack. Again, in terms of treatment, these do play a role. We'll talk about that more in the next lecture. So let's move on to ICG, and then we'll be done here. ICG in central serous causes these dilated choroidal vessels to get congested. You get choroidal staining and leakage, and this usually shows up in the middle and late phases of ICG. And then you can characterize it as sort of mild, moderate, or intense. And that actually has some predictive value for therapeutic response. Again, talk about that next lecture. And some folks that have central serous are not going to have any hyperfluorescence on ICG, which is important as well. This is a patient's 42 years old, history of reflux, started on a topical steroid cream 1 week prior to symptoms. This is the 60-second ICG. You could see on the fluorescein I have over on the left, a little tiny white dot starting to show up for an expansile dot. On the right, not much to say in the ICG just yet. Now on the right, you're starting to see that expansile dot show up as well. And just temporal, just left of that blister of subretinal fluid, you can see this little bit of hyperfluorescence showing up on the ICG. And now that's more prominent, that little ICG area of hyperfluorescence, that's abnormal. I call that mild to moderate staining. And there's probably a little bit right in the center of the fovea too, kind of encompassing that little expansile dot, and then just inferior and temporal to it. If you can kind of imagine, that's a little bit hyperfluorescent. So here's, again, this is a patient I already talked to you about, has a type A, who is type A, has obstructive sleep apnea and GERD. This is a recurrence of subretinal fluid. We did this scan prior to his therapy so I could take some measurements. You could see his fluorescein shows that guttering. ICG is already showing some hyperfluorescence. And here it's a little bit more prominent. I would call this intense hyperfluorescence on the ICG centrally. And here's his late image. At 14 minutes, you could see, and he also has a smokestack, by the way, on the FA, if you didn't notice that, and that smokestack showed up on the ICG as well. This is a patient who has an 8-month history of subretinal fluid, and he had an 8-month history of subretinal fluid presented to me. Here's his fluorescein angiogram and ICG. You could see between the fovea and the disc a small white dot appearing in the FA. On the left, you can also see multiple other sort of areas that are beginning to stain or have some hyperfluorescence. It's well circumscribed on his FA. His ICG is not showing a whole lot at this point, maybe some mild hyperfluorescence between the fovea and the disc. It's more present now, and then I'll show you a few more images here. Well, here's a little movie of his stills. And you can see that, this is the other eye now. But you can see multiple areas of hyperfluorescence both on the FA and the ICG. The ICG is fairly diffuse, and I would call this moderate to intense. So we'll talk more about that in the next lecture when we dive into treatment modalities. It'll take me probably a month to get that one together. And anyway, just again, wanted to mention I'm moving to Burundi in a couple of years, I'm leaving in a year to study French, and we're raising support. There's my family. If anybody would like to donate, we would appreciate it. You can go to this website to donate or Google Baskin space WHM. I think it's the first hit. for a link to donate. And I also have a WordPress site where I try to keep some of these differentials up to date, and then my wife's blog about our upcoming trip or move to Africa, and then of course the website, YouTube, where you're probably watching this. Here are my references, and similar, there's some new ones I added on for this part 2, and that's it. Thank you very much for your time.